morning, everyone, and welcome to today's webinar presentation on first-line nursing responses to intimate partner violence. My name is Sarah Carsley. I'm an applied public health science specialist at Public Health Ontario, and I have the pleasure of co-moderating today's session. I'd like to first acknowledge and respect the lands, sky, and waters of Ontario, including for their contribution and sharing to support all life within. I acknowledge and respect the treaty, unceded, and traditional territories of all First Nations across these lands and waters. I would like to acknowledge that I am in Toronto, on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. Please join me in acknowledgement and respect of all Indigenous peoples, their life journeys and worldviews. May their wisdom always guide our own paths forward with open hands, open hearts, and open minds for the mutual success and benefit of all in Ontario. I will now mention some housekeeping items. To ensure an engaging and optimal experience for all, the Zoom chat and audio-video features have been disabled for this session. Please feel free to submit any content-related questions in the Q&A function at the bottom of your window. They will be addressed during the discussion period. For technical issues, please email capacitybuilding@oahpp.ca. I would now like to introduce my co-moderator for today, Sonia Strom. Sonia is a program manager at the Public Health Nursing Practice, Research, and Education Program, or PHN Prep, at McMaster University's School of Nursing. She supports project management, research, and knowledge translation, collaborating with public health nurses and managers in Ontario's Healthy Babies, Healthy Children, and Nurse-Family Partnership home visitation programs. Welcome, Sonia, and I'll pass it over to you.
Thank you so much, Sarah. I'm thrilled to be here today co-moderating with you and representing the work of the PHN Prep team in supporting public health nurses, supervisors, managers, and home visiting staff in their work with families. It is now my pleasure to introduce the speaker for today's presentation, Dr. Susan Jack. Dr. Susan Jack is a public health nurse leader whose research focuses on how nurse home visitation interventions can improve maternal-child health outcomes, including the prevention of family violence. As a professor at the School of Nursing at McMaster University and the lead of the Public Health Nursing Practice, Research, and Education Program, she is passionate about documenting the work of public health nurses and applying evidence to advance public health nursing practice. Dr. Jack is currently a member of the expert panel that has been engaged to update the RNAO best practice guidelines for identification and response to intimate partner violence. After more than a decade of being a soccer, hockey, rugby mom, Susan and her husband are now enjoying life as semi-empty nesters and having more time to curl, golf, and study Italian. So without further ado, ciao, Susan.
Great. Good morning. Thank you, Sonia, and thank you, Sarah. Always such a pleasure to be here with all of you. On this gorgeous fall day, I want to start by recognizing the important and often very difficult work that each of you do in your different roles. Supporting families in brief and sometimes very intense encounters is not easy work. It asks a lot of your skill, it asks a lot of your heart and of your energy. I also want to acknowledge today that among those of us who have gathered here for this webinar, there will be people themselves who have experienced intimate partner violence, whether personally or through someone close to them. If that is true for you, please know that you are not alone and that you are welcome in this space in whatever way feels right for you. Talking about IPV or even listening to someone talk about IPV can bring up many different emotions. So I encourage you to take care of yourself as we move through this session. Step away if you need to, take a breath, or reach out to someone afterwards that you trust. Most importantly, I really want to begin with hope. The conversations that you have with your clients or with your staff who may be experiencing IPV, or with a trusted colleague who comes to you, or even conversations that you have with another mother or individual who you meet sitting on the sidelines at hockey or soccer or rugby or dance lessons. These conversations, even short ones, can open doors, they can plant seeds of hope and help people feel less alone. Your presence, your listening, and your compassion can make a difference. So thank you for bringing your commitment and your interest and your care to learning how to do this work in a safe way, and thank you for being here today. So the first thing I'd like to do is I'd like to invite us all to begin together today with just one small act of care for ourselves. So wherever you are, just place your feet on the floor if you're able to. Feel your feet on the floor if you can, and just notice your breath. Just take a moment to feel yourself breathe in and out. And this is just a reminder that we are here together in this moment. And as we move today through the webinar, I invite you to carry that reminder with you that your well-being matters, that you are not alone in this work, and that even the smallest moments of presence, putting your feet on the ground and taking a breath, provides compassion for yourself and for others, and it can be very powerful. So in thinking about this webinar, there's something I've come to recognize over the last few years, or appreciate, is that if you are a public health nurse or a family home visitor or anyone else who works in the community with pregnant individuals, with families, with parents, is that sometimes our interactions are differently defined by the amount of time that we spend with individuals. If you work within a home visiting program, Healthy Babies, Healthy Children, Nurse-Family Partnership, or any other program that involves, or even primary care that involves the development of a therapeutic relationship over time, over multiple sessions with an individual or with a family, you are able to identify and respond to intimate partner violence in a very in-depth way with multiple assessments, with a range of interventions, in working collaboratively with the client, because you have a lot of time with that individual. The reality, though, for many other roles and responsibilities and activities that you engage in, is that you're not engaging with clients in over a long relationship. Very often, your work may reflect short, episodic encounters. So I'm thinking of screening liaison nurses who, are at the hospital, seeing a family just after the infant has been born, completing the universal postpartum checklist or screen or assessment. There's, a question on there that asks about observation or indicators of strain in a relationship. Or maybe you are a nurse or an individual who works in a group setting at an early years center, or you're teaching parenting groups, or you're at a vaccine, you're delivering vaccines at an immunization clinic. In all of those settings, you have a brief episodic encounter with an individual. And you may come to become aware of IPV, or you may hear a disclosure, and you only have 5 to 10 minutes with an individual. And in that short period of time, it may be a default for some clinicians to start to think, okay, well, there's only 5 to 10 minutes, what can I do? Or if I do start to do something, it's going to open up Pandora's box, and I still have 10 more clients to see in clinic today. So the goal for today is to share with you, actually, you can do a lot in 5 to 10 minutes or even shorter, and to initiate the process of how to identify and respond to intimate partner violence. So that's going to be the goal today, is to give you some insight, a process. If you only have 5 to 10 minutes with someone, essentially, what can you say and what can you do? So to start off with, why is it critical? I really believe it's essential that any healthcare professional or anyone that works with the public as part of a professional role really should have some basic knowledge, skills, and confidence on being able to recognize when someone may be at risk for intimate partner violence, and to know how to start a conversation, and to know how to, at its basic, respond to a disclosure. And why do I think every healthcare professional should know how to do this? Well, because intimate partner violence is so common. It is a social and health condition that impacts the lives of so many Canadian women and Canadian individuals. So when we look at broad population level data, in looking at lifetime experiences of sexual or physical violence among women over the age of 15 years, at least 44% of the population has experienced at least one incident of intimate partner violence. So that's at least half the population of individuals who identify as women. However, when we begin to look at individuals who live at the intersections of race, of gender, of disability, we start to recognize that there are individuals who experience intimate partner violence at disproportionately higher rates. So you'll see here on this slide that an LGBTQ2 woman who also has a disability, the rates of intimate partner violence across the lifespan, almost 3/4 of that population have endorsed experiencing intimate partner violence. Similarly, for Indigenous women, another population that experiences disproportionately high rates of violence. So when you look at these statistics, it's pretty fair to say that whether you know it or not, probably all of you, if you have worked with in client-facing situations, have engaged with someone who has a history of or who is currently experiencing IPV. It's that common. And so given that it's that common, universally, we should have, all of us, some basic skills on how to navigate a conversation about IPV. So what I hope to offer to you today is an acronym and a pathway just to think about, if in those 5 minutes I only have time to do a few things, what are those few things? And this is the Relieves pathway. And our team has adapted this and expanded it from the World Health Organization's Lives protocol. And essentially what I'm going to walk you through today is that in any clinical encounter, I want you to have some basic knowledge of understanding what are the indicators of IPV, so that if you see those indicators, you recognize them, that prompts you to engage in a discussion of relationship safety, being able to ask one or two open-ended questions just to open up a space for conversation, to remind yourself that an important part of engaging in a discussion is listening actively, that if your discussion prompts a disclosure, someone saying, yes, I'm experiencing IPV, that you know how to respond, that you have some scripts stored at the back of your head where you can, instead of sputtering and not knowing what to say and avoiding, you have some statements that will roll naturally off your tongue and provide that empathic response. And then knowing that you have a capacity that even in those 5 minutes to say, in our short time together, what is your immediate concern and how may I assist with that? Identify how you can assist meeting those needs. Validate that you have heard what they've shared, and then move to a process of referral often, so that you can, if the person is open to it, transition to thinking about safety and support. So that's what our Relieves pathway looks like, essentially recognizing, creating a space to open up a conversation. If there's a disclosure, responding empathically, validating their experience, identifying in the short period of time if there's one thing they need, what is it that you can do, and then starting to facilitate through a process of warm referrals, a warm handoff to someone else who has more time and more in-depth skills in assessment and intervention. So that's the process. We could end here, but I'm going to go through each one of these steps in a lot more depth. And this pathway, important to think about as well, is always grounded in doing our work in a way that reflects using the principles of trauma and violence-informed care. And the first principle of trauma and violence informed care is being trauma and violence aware. And that really reflects that first step, recognizing that, among humans universally, trauma is very common. And intimate partner violence is one of the most common forms of interpersonal trauma. So again, recognizing how prevalent this social and health condition is, we need to be constantly aware as people are sharing their histories with us, as we look at their behaviors, as we observe how they interact with their partner, as we learn a little bit more about their history, we need to be aware of the potential that they may be experiencing violence as a source of trauma. And we don't need to know all the details. That can be very traumatizing to ask someone to repeat all the details of their experience, but we just need to be aware of these indicators so we know when we create space for a discussion. It's critical in doing this work that we always prioritize the physical, emotional, and cultural safety of individuals. So anytime that you're going to have conversations about intimate partner violence or open up that space for a discussion, ensuring confidentiality and privacy is really important. And I know in a hospital room or within an acute care setting, sometimes that can be difficult, or in a group setting, if you're working with a parenting group or some other group. It's important to find space to ask someone, can I speak to you privately? Can we come over to the corner? Can we go over into this other room? Invite the partner to go get a cup of coffee for everyone. But important that this conversation happens in privacy, because individuals may not want to speak about their experiences, or they may be afraid to speak about their experiences in front of other individuals. And the other thing that's important to remember about is that when we open up these discussions, we're creating space for choice, for collaboration, for connection, and for building on people's strengths. This may be the first time that someone shares with you that they're experiencing violence in their relationship, and that can be very frightening because they don't know what to expect. So we're not in a position to force anyone on what to do. We're here in a role to say, here are some options for safety and for additional support. If you are open to them, may I help facilitate you connecting to these other supports. If someone has been living with violence for a long time in their life, they may already be implementing different safety plans for themselves and their children. And so when we look from a strength-based approach, it's very helpful for us to even say, what are you currently doing to keep yourself safe? And how can we build on those strategies? So I ask you, as you use this pathway, to think about how important it is to nest these skills and these processes within the principles of trauma and violence-informed care. Okay, so let's get to the first step, recognizing the indicators of intimate partner violence. And to me, once I have these ingrained in my head and that I know them, you start to see them everywhere. And again, as Sonia shared, I was a sports mom for a long time. And there's at least two distinct times I remember sitting, once in an arena, once on a soccer field, and over time starting to go, what's happening here? What's happening in this relationship? I'm starting to see some of these indicators. And sure enough, over time, it revealed relationships characterized by intimate partner violence. Also in 2021, 2022, I returned to Wellington Dufferin Guelph Public Health as a casual public health nurse working in the vaccination clinics. And, as hundreds of people received their COVID-19 vaccinations, you could start to see there were times when I would see some of these indicators and I would go, I have about 5 minutes. I'm starting to suspect or think that something else is going on. How can I open up a brief conversation? So what are the indicators of IPV? And there are many, but these are the most common ones. The first thing to look for, I think, are the ones that are most evident and obvious to healthcare professionals: clinical signs and symptoms. If someone's experiencing physical abuse, you may notice signs of injuries, bruises. They've talked about history of fractures or broken bones. You may say chipped teeth. You may see if it's been a recent strangulation or choking, redness around the neck. They may talk about a history of traumatic brain injuries or concussions with vague details. So those are the first most explicit and obvious signs. And often you may start to, if you ask about an injury or a past injury, and the information that they share with you doesn't really align with how an injury of that type might have occurred, all of a sudden too, that starts to become a little bit of a red flag to you of going, I wonder what's happening here. But the evidence also indicates that individuals who experience intimate partner violence often report significant levels of fatigue, ongoing experiences of chronic pain, somatic complaints, right? So non-specific GI symptoms, migraines, the backache, the body aches. And you may often hear, that trauma lives in the body. Individuals who experience IPV report significantly high levels of mental health concerns, particularly anxiety, depression, and PTSD. For individuals who experience reproductive coercion or sexual abuse within their relationships, you may see an ongoing history of STIs, recurrent UTIs. Now, I'm not saying everyone who comes to your sexual health clinic or who's talking to you in a postpartum home visit about a history of UTIs means that they are experiencing IPV, but these are some of the indicators, and you're starting to paint a whole picture and putting multiple indicators together. There might also be behavioral signs. So there may be individuals who have had delayed or inconsistent prenatal care. Now, there's a lot of reasons why people may not be accessing prenatal care. But one reason is that they're engaged in a relationship with a partner who uses power and control, who has coercive control over the individual, and who does not give them access to a car to get to their appointments, who does not facilitate helping transport them to their appointments, who really, to manage that control, does not want the pregnant individual to go to seek a health care in fear that maybe they share something with the healthcare provider. So again, that's one piece of the puzzle. Or conversely, you may have an individual who talks about having a lot of emergency room visits or ongoing visits to their primary care provided for treatment of injuries, for assessment of all of these non-specific complaints. So, because there's evidence to support that individuals who experience IPV have increased use of emergency room visits. Now, within an encounter, you may also see that it's someone who looks to their partner. You may ask them a question, they look to their partner for the answer, or the partner quickly jumps in to answer. So these are, again, just cues where you start to go, there's some red flags here. And then when we look at the evidence of what suggests are risk indicators, evidence-informed risk indicators, and these are additive, it means that the more risk indicators that someone has, the increased likelihood that they may be experiencing or an increased probability that they may be experiencing IPV. So typically IPV is reported in individuals of young age, individuals who are recently separated from their partner, if the partner is unemployed or working less than part-time, if there's a history of depression, either in the client, the individual who you're assessing or suspecting might be experiencing IPV, as well as a history of depression in the individual who you suspect may be a perpetrator of intimate partner violence, or someone who is engaged with a partner who is a user of alcohol or other substances. So these are all the indicators or red flags to be mindful of. And if you start to see a pattern or constellation of them, it should say to you as a healthcare provider, this is someone where it might be worthy of engaging in a discussion around healthy relationships, beginning to open up the conversation. And this can be done in asking one or two open-ended questions. So often, I think almost probably every public health nurse knows the skill of asking normalizing questions, saying, these are questions we ask all of our clients. Or as part of my practice as a public health nurse, we value talking about the importance of healthy relationships. So you might start to say something like, many new parents find that their relationship might change after their baby is born. It can be stressful, and sometimes people don't always feel supported in the way that they need. How are things going for you in your relationship right now? So for those of you who are screening liaison nurses, and if you're assessing someone in the hospital using that universal postpartum screen, and the partner or no one else is present, I know there's a lot of ifs there, this is the type of statement that you can use just to open up the conversation. Now, many of you who are working in group settings or parenting settings or even on an intake line, you can adapt this type of question. The purpose is just to open up a conversation, to acknowledge and validate that relationships sometimes can be stressful, and to invite, to create space to ask the person to reflect and create space without any assumption that there is IPV or any judgment. And again, you're engaging in these discussions in most cases where you've already started to see that there's a bunch of indicators. And now you're trying to create space to determine, are those indicators related to something else? Maybe depression or anxiety without intimate partner violence, or maybe these indicators are indicating that there is violence occurring within the relationship. So once you engage in that discussion, as you think about, you're creating space, you're opening those conversation with those first open-ended questions, you might then continue on with the discussion by providing some gentle education, and not a lot, just a sentence or here too, again around the value and importance of healthy relationships. Many new parents find that their relationship might change after the baby is born. It can be stressful, and sometimes people don't always feel supported in the way that they need. Create a space for a disclosure. Open that question and just sort of let it hang there. Sometimes people may feel scared, controlled, or hurt by their partner. If that ever happens to you, know that you are not alone. No one deserves to be hurt, and supports are available if you'd ever like to talk more about it. And what I like about this type of statement is it's inherently giving choice. If that ever happens to you, we're not saying this is happening to you, but if this ever happens to you or someone that know that you're not alone. No one deserves to be hurt. So we're already starting to frame a different script for them, because often a perpetrator convinces the person that they are responsible, or that they're to blame for the violence that they're perpetrating. And we're opening it up to say that supports are available if you'd ever like to talk more about it. And they could say, oh, no, thanks. No, that doesn't appeal to me, or I don't need that. But at the back of their mind, you've just planted the seed or the idea of hope that there are supports out there. And you've also presented that as a healthcare professional, whether it's you or the next one that they talk about, that this is a topic that they may choose to open up to with their nurse or another healthcare professional. So again, I really believe in the value of thinking ahead of time around what might you say. Because often disclosures in your work, even though IPV is common, hearing a disclosure may happen relatively rarely in your day-to-day work, depending on the population that you work with. And when clinical events are rare, and sometimes we hear some shocking news, or if someone opens up and tells us some very difficult emotional or abusive events that are happening in our lives, it can catch us off guard. And when we get caught off guard, sometimes it's easy to avoid, switch topics, to stumble with our words, and to really be present in that moment. So what I encourage you all to do is, if someone discloses to you, or as you're having these conversations, give yourself time, again, always to take a breath before you respond, and start to think about what are one or two of these statements that you're always going to have tucked at the back of your head, just in case you get a disclosure. So if you're talking to someone and, they have presented with some physical injuries, or they're telling you that they've been feeling more depressed and it's stressful now in the postpartum period, you've noticed on your last few encounters, or, it was hard to get the partner to go get a cup of coffee. Once you have them alone, you might start to summarize what you've seen. Like, I've noticed, or I heard you say. Again, validate, share with individuals. IPV is common and affects many people, and we often ask about these experiences. And if you only have those 5 minutes with someone, so again, those brief episodic encounters, there is some evidence that suggests that asking a fear-based question is one of the more powerful questions to ask, to elicit or to support someone, if they're ready, if they choose to share with you what's happening in their relationship. So you might ask a question, again, after you've started this conversation: are there times when you are fearful within your relationship? Are there times you worry about your safety or your children's safety when you are engaging with your partner or their parent? So again, if you only have a short period of time and you need to think about what is the key question to ask, you may consider asking a fear-based question. So now we've recognized the indicators, we've engaged, created a space with even an open-ended question, a single open-ended question, creating space for disclosure. Again, if an individual chooses to disclose to us, we need to be prepared to listen actively. This is a huge piece of information, and it takes a lot of trust for a client or an individual to open up and share what's happening in their relationship with another person external to their family. Because there is fear there. Their partner may have said to them, if you tell anyone about what's happening, no one's going to believe you, because they already know that you're crazy, you have depression or anxiety. Do not tell anyone, because if you tell someone, this is what's going to happen to you, or this is how I'm going to hurt your dog or the children. So know that this process of sharing with you as a healthcare provider requires trust, that they are trusting that you will hold this information safely and that you will engage without judgment with them. Because sharing this information may come with a lot of fear. And many individuals also may fear that if they have children, and recognizing that, intimate partner violence, when children are exposed to intimate partner violence, that is a form of child maltreatment. So families are also calculating their own risks, or individuals are calculating their own risks of when and how to share this information with a healthcare professional, because there's fear. So how do we, again, lessen that fear? We do this work in privacy. We talk about the limits of confidentiality, and we create this space to hopefully create a sense of emotional safety for the person that's talking to us. And we can do that in a way of how we present ourselves. Anyone who whips into a hotel room, a hospital room to do an assessment, or whips into a clinic room, or whips into a group, or answers the intake phone and starts to ask a bunch of checklist questions, and who's just trying to complete their agenda, and you're all busy. But if we're moving in that fast-paced tone and that busyness, and people just feel like a number, that does not feel safe to individuals. And they'll probably just answer your questions with yep, nope, yep, nope, yep, nope, and not really give you a lot of information. Creating safety and active listening, again, even within a 5-minute period, means that as we encounter clients, that we, as much as possible, this requires us breathing in our own regulation, that we're using a calm tone. We don't let them see that we're busy and we have a lot of other things to do. We use non-threatening body language. Is it okay to pull up a chair and sit by the bedside? Is there a way that we can get eye to eye with someone? Is there a way to just even slow down our own breathing? Be present. Listening actively means being present. We're not looking at our paper in front of us. We're not looking at our phone. If there are other interruptions, we say, I'll be with you in a moment. We push those aside. As much as possible, again, if our goal is to support someone to share with us what's happening in their relationship, we need to be present. Validation is really critical. Acknowledge their feelings, acknowledge what they're sharing, validate that you hear what they've told you, validate, reflect back their emotions, that this is really difficult. Allow people to tell their narrative at their own pace. And for a long time, there was a push for screening and a lot of in-depth assessments, asking individuals around every type of abuse they've experienced, how often, how frequently. And there may be a place for that in some settings, especially if you are a sexual assault nurse examiner or in forensics, or you have some of those long-term relationships where you're thinking about what interventions are needed to address or respond to different types of abuse. But in these short episodic periods of time where you only have a little bit of a time with a client, you don't need all the details about everything traumatic that has happened to them or all the details about their intimate partner violence. That can be harmful. It can be re-traumatizing in that short setting for them to share all of that with you. It is enough for them to say to you, yes, I'm fearful of my partner. Yes, the reason I didn't get to prenatal care is because my partner refused to take me. Yes, my partner is threatening to hurt my dog or take my pets away if I leave or talk to someone. Yes, I had a broken clavicle. It's fine now. But that was from a physical assault from my partner. If that's all they tell you, that's enough. We don't need more details. Validate back that you've heard them and that this must be very difficult. If you have time and you see they're starting to share with you, just use open, gentle prompts. Would you like to tell me more? And listen to their response. If you're sensing that they don't want to go further, remember those principles of trauma and violence informed care. This is about choice. It's not about getting them to tell us that they're experiencing violence, which is often the process of screening. It's about creating space. If they're ready to share with you what is happening, and they're having hope that you then will have a response that validates their experience and a response that also helps connect them to someone who can support them with safety. So that goes with respect and control. Let them lead the conversation. We don't need to pressure to a disclosure. Notice their body language. If the individual is starting to become dysregulated, they're looking at their phone, they're starting to shut down, they're starting to say to you, oh, I can't remember the details. They get defensive, they start to get distracted, they switch the conversation. Recognize they're going into protection mode. Their body is starting to, say, oh, this is not safe. Those are all behaviors you might notice that are, the flight or the fight or the fawning or the freezing motions. So if you're starting to see someone become dysregulated in these conversations, really important again that you go back to using those mirror neurons. Just slow down your own breathing, lower the tone of your own voice, and hope to get them back to a period of regulation as well. And you may say to them, would you like to continue this conversation, or is this a conversation for another time? And if they say, I don't want to talk about it anymore, leave them with a resource, and we'll talk about resources in a minute. Believe them, no matter what they share with you, accept what they share as their truth. Don't judge, don't minimize, and don't be doubtful. Validate their experiences. Again, you may be one of the first people that believes this individual. And stay grounded. Be really aware of your own reactions to be supportive and non-reactive. And there's a few situations here where it's really important. Among healthcare professionals, we estimate, again, that 25 to 44% of healthcare professionals themselves have their own experiences of intimate partner violence. So as someone is sharing their experiences, it may be activating your own emotions related to your own experiences. The other situation is some individuals, once they start talking, they may open up because they trust you so much and start to tell you about some very horrific events. I've heard disclosures that have involved pregnant women being pushed down the stairs, being tased, being choked with a cell phone cord. And these are horrible events to imagine. If we start to become very reactive, the individual that's talking to us might start to go, oh, this is too much for them. I need to shut down. So we need to acknowledge how difficult this is, acknowledge that no one deserves to be hurt, but again, be mindful of how we're presenting and that we don't get so upset that the person starts to shut down. And again, I just put this slide up to remind us of the space that an individual who's experiencing violence may be sitting in, and to think about, we can ask all the questions in the world, we can create emotionally safe spaces, we can be non-judgmental, we can validate their experiences, but there's many reasons why they may not choose to disclose to us in that period of time, in that space. Because of fear, because of recognizing the stigma associated with being an abused woman or a victim, a fear that their partner may retaliate if they learn that they've shared. They're constant thinking of how will this serve me telling this information, the safety for myself or my children. And also recognizing that individuals who have experienced trauma, and particularly ongoing chronic sources of trauma, such as interpersonal violence, may live in places of hopelessness, may experience constant intrusion from multiple systems, and may just fear, well, if I say something, what's going to happen? Why would I even share this? Because they have no hope that anyone will hear their story. So remember that this may be the place that they're sitting in, and how do we be the counter to that? So if you do all those great things, you recognize the indicators, you engage them in a discussion, you're listening to what they share, and in that brief 5-minute encounter, they say, no, everything's fine, nothing happening here, or they shut down, that's a no disclosure of intimate partner violence. And so I would recommend that there's two things to do in that situation. One, recognize that truly there may not be intimate partner violence, and those indicators you saw may be indicators of something else to assess, or it's a false negative. And that means that the individual wasn't ready to share to you in that moment, and it's nothing about you. You were asking the right questions, you were creating the space. It's just that they were not ready or feeling in a place of safety to share, but that there really, a false negative is they didn't share the information, but there really is IPV. So in this case, I think it's really important that you end the conversation by reiterating how important it is for people to have relationships that are characterized by safety and respect. And that if them or anyone else in their family or friend circle ever experience fear or a lack of safety in the relationship, to know that there are resources in the community and to leave them with a source or a resource. Information about health supports, the intake line, domestic violence services in your community, linking them to a website of resources. And by doing that, we've said there's resources out there. We've told them where they're at. So we're giving them agency when they're ready to act on their own. And to let them know, again, that if any concerns ever arise in the future, again, here's who they can take the agency, make the individual choice to contact. So really critical as a healthcare provider that you hold the knowledge of what are those resources in your local community that you can refer people to, or to at least tell them about. Now, the other option is that you've done a brilliant job of opening up the discussion. You asked if they feared of their partner, and they say, yes, here's what's happening in my life. And they start to open up and disclose their experiences of IPV. And again, I want to reassure you that even within a 5 to 10 minute episodic encounter, even though it's taking me an hour to unpack all of this, you can do this. You can ask an open-ended question. You can create space where you're actively listening and encouraging them to share their narrative. And in that space, if they feel that it's the right time for them to access resources, to need support, they recognize that you are someone who will be able to link or facilitate them to another resource, they may choose to talk to you and tell you about experiences of coercive control, of physical abuse, of sexual abuse, of reproductive coercion, of economic abuse, of emotional abuse, which includes being threatened, being put down, being harassed, tech abuse, right? So increasingly we're hearing about partners who surveil their partners using their cell phones, or controlling different devices in the home. If you hear any of that, you must acknowledge this disclosure. And again, here's these situations where it's so valuable to have a few little statements tucked away at your back of your head where you can respond to this disclosure. And some early research on research teams that I was a part of that conducted surveys with healthcare professionals around barriers to asking about IPV. One of the most common barriers to even asking about IPV was that if someone disclosed, healthcare providers said, we don't know what to say or do. So we're not even going to ask, because if we get the answer, we don't know what to say or do. So here are some principles to think about so you do know what to say. Focus on the strengths. Thank you. It took a lot of courage to tell me this. Acknowledge the complexity of the situation. And I think this is a big one. Because sometimes as healthcare providers, we're already jumping 30 steps ahead. Oh my gosh, I've just learned this. Now I'm going to have to do this. Then I'm going to have to make a referral to this. How is she going to escape this? She just told me about this. And it's really complex. Well, your client or your patient and the individual in front of you is also feeling that complexity. And I'm here to tell you, in a 5 to 10 minute episodic encounter, you are not going to stop the intimate partner violence. We are not going to solve this challenge. So it's important, I think, to acknowledge to someone, addressing abuse is a complex process. Thank you for sharing this with me today. This is an important first step. After we identify what are your key priorities today, I'm going to, with your permission, link you to someone else who can spend some more time to help you find strategies for safety. So if you're feeling it's complex, acknowledge that and just acknowledge this is just a first step, but I'm not leaving you today until I transition you off if they choose to someone else. Challenge inaccurate beliefs. Perpetrators of violence do a really good job in making women or individuals who experience violence feel like they're to blame for the abuse, that they deserved it, that no one else could love them, that they're not a good mom, that they're not going to be a good parent, that if she ever left, who would take her? She'd have to parent alone. They're very skilled in consistently gaslighting and building these messages, these inner thoughts within an individual who's experiencing abuse. And that diminishes the person's sense of agency, self-efficacy, self-confidence. And we can, again, be the counter to that. So if they're like, yes, this event happened and, he did, push me up against the wall, but it's because, I know that he gets irritated when the baby's crying. It's really my fault. We may hear these things. We can be the counter to that. It is important that we say everybody deserves to feel safe in a relationship and no one deserves to be abused. You do not deserve to be abused. These are powerful statements. Really critical too, that our role is to offer support and advice. Do not advise someone to leave a relationship. Leaving a relationship is the most dangerous time for a woman. It increases their risk of femicide. So it's really critical that we don't tell them what to do, particularly we don't tell them to leave the relationship. We can start to offer supports and offer them choices. And the process of leaving needs to be ideally done within the context of a good safety plan. We focus on solutions. Sounds like you've been dealing with this for a long time. What are some of the safety strategies you're already using? How can we build on this? Or before you leave the hospital, or before you leave this parenting program today, if there's one thing that I can do for you today within the parameters of my role in this short period of time, what would that be? So those are things to think about, what to say if there's disclosure. And I'm also going to tell you what's really critical, that the evidence supports a lot of this grounded in qualitative evidence from talking to women who've experienced IPV about what not to say. Please don't avoid. Avoidance means we don't have a script, we're not comfortable, we don't know what to do. I'm telling you, you all know what to do. The most important intervention is to actively listen and acknowledge and validate. So if we avoid and say, wow, that's not good. Oh, didn't you want to talk about breastfeeding today? That person is going to learn that we're not comfortable talking about this, that it wasn't safe to talk to a healthcare professional, and it may delay them talking from it to another healthcare professional in the future. So even though it's hard, acknowledge what they've said. All you need to do is say, thank you for sharing that with me. This must be very difficult. Would you like to tell me more? And then just listen. And all of you I know are very skilled in active listening. Try not to find a silver lining in this situation, such as, well, at least your kids have a dad. A lot of other women may have partners that disappear. Don't try to find a silver lining. Don't minimize. Don't make excuses for the person that's perpetrating the violence. Like, well, I've seen that your partner's also under stress, and it's not like they're probably doing this intentionally. No, do not minimize. I've already talked about don't give advice. As soon as you start to hear yourself say you should, or why don't you, anything with should or why, those kind of statements are often perceived as judgmental and as advice giving, and people will often throw up their defenses. This is not also the time to tell a story to try to relate. Well, I know someone else who went through this and this is what they did. That person's like, no, in this moment, this is about me. And we've also talked about making sure that you maintain your own sense of regulation and try not to have too much of an emotional response. So again, in that 5-minute period, 5 to 10 minute episodic encounter, ask them about their immediate needs. I only have a short time with you today. Is there something that I can do with you within the next 5 to 10 minutes that will help you feel safer or address one of your priority needs? Many individuals may fear that the person's going to say, yes, help stop this violence. Let's stop this. That's often not the case. They may say, I really have no access to finances. And, do you know any resources that can help me get infant formula? Or I don't have transportation to my prenatal appointments or to my primary care provider. Can you assist with transportation or link me to someone about that? So ask them, what is their immediate need now? And then identify how you can meet that immediate need. If their needs are more expansive, more comprehensive, then your response will be, okay, let's think about who I can connect you to through a warm referral, and would you be open to that? So it might be a need that you can meet immediately, or it might be a need that also requires you to do that step of a warm referral. So as you start to think about how do you identify a solution to their needs, here are things to think about. Safety and control. We're always doing this within a context of safety, of privacy, giving the person choice. I'm going to present some options to you. Which one of these resonates with your situation, or which one makes the most sense to you? Identify that at this point in time, the individual may say, the relationship is as the relationship is. I don't have anywhere to go. My partner provides childcare. He's the only one earning money in our house, but my priority need is my emotional and mental health. Okay, so as a healthcare professional, that's an indication that either you or someone else needs to do an assessment or screen for depression, anxiety, and click into a pathway for getting them support for emotional and mental health. Or is it about facilitating connection to social support? And as you're doing this, really be mindful of what are some of their past experiences with the system. Many individuals do not find systems, legal systems, healthcare systems, education systems, child welfare systems, the police system helpful. So we can offer those as options, but recognize that individuals may be hesitant to engage because of their past negative experiences. And this is the value of warm referrals, of connecting someone, not just giving them a phone number or a website, but actually supporting them to navigate a system, is that sometimes it can facilitate that trust building to link them to another system. And sometimes people are going to just ask you for something practical. Access to, again, transportation, addressing issues related to food security, housing security. They may just have some really practical requests for you. Now, in our relieves pathway, the V stands for validate current and past experiences of IPV. And, to make a word of an acronym and to fit with the World Health Organization's lives protocol, we needed the V in there. And this process is not always linear. And I think the V, the validate, is one of those steps or processes that you do across this whole pathway, that you are always validating the individual. And when I say validating, it means that you are believing them. You are not minimizing, you're not questioning them. You are acknowledging what they are sharing with you as their truth. So validation is critical. This will help to continue to build the trust in the relationship. So now in this, and again, 5 minutes, you've recognized some indicators, you've asked a powerful question, you've created space to listen. If the person chooses to disclose, you encourage them to share what they want. You ask them, okay, in this time I have with you, what is your most important priority? How can I best support you? The other thing that I would like to do is to connect you, with your permission, to another healthcare professional, whether it's another public health nurse within the organization, a social worker within the organization, or a community resource, the SV, the Sexual Violence and Domestic Violence Assault Center, or shelters within your community. You'll know the resources in your community. Maybe then you're offering, can I connect you to another individual or organization in our community who will have more time, skills, resources to more comprehensively address your concerns. So making this warm referral is a really critical step for you to support enhancing the person's safety and connecting them to other supports. So here are some questions that you can ask them to facilitate that process. Again, what are you currently doing to keep yourself and your children safe? Are there other options you would like to explore? If you're going to ask that question, you need to be aware of what are the other options in your community that you can offer to them. And would you be open to me connecting you using a warm referral process to another healthcare professional, social care provider, or another organization? And I think often in these episodic encounters, this will be what you'll be doing, offering support, offering some options, and facilitating a referral or connection. And knowing too that we want to facilitate an individual's agency, allow individuals to make choices that make sense for them, their family, and their situation, recognizing that many individuals will say yes to a referral or yes to taking information, but may experience anxiety or other barriers to connecting with that resource or connecting with that other agency or provider. Knowing all of that, another option to provide to individuals is the recommendation or telling them about an evidence-informed app called iHeal. Now, the iHeal app has been developed by nurse researchers, a team led by Dr. Marilyn Ford-Gilbo out of Western University. This app is evidence-based. It has been evaluated. It is an app that allows an individual or healthcare providers to download the app. It has all sorts of safety mechanisms built in it, but it allows an individual to go in to assess their own safety needs, and the algorithm in the app helps generate safety strategies and connection or links to Canada-wide resources. So this is another option, is also to share with someone, and again, if you're thinking about safety options, you're not ready to be referred to another agency, let me tell you about the iHeal app. And it's something that they could access on a computer at a library if they're afraid that their partner is monitoring their phone, or it could be something that you have on your phone and you show them how it works. So I'm just giving this to you as an option of a resource that you can give to clients so that they have their own agency to do their own assessment and act on resources at a time that makes sense for them. And as I get to the end here, I often think too, what makes this work difficult for healthcare providers is, again, we're thinking about the complexity and all the what ifs, and we're carrying our own emotions to this work. And we're thinking about all the things that we need to do. But I'm here to give you some reality and say what we really don't need to do in these brief episodic conditions, whether it's, again, a clinic, a vaccination clinic, a parenting group, you're a screening liaison nurse. The reality is you may only have 5 to 10 minutes. And some of you may be saying, Susan, we don't even have 5 to 10 minutes. So it's important for you to give yourself permission to recognize what you can do, recognize indicators, ask a powerful open-ended question, create space for a disclosure. If they disclose, listen, validate, ask them what is their priority need right now, and then a warm referral to resources or share information about the iHeal app or resources in your community. That's what you can do in a short period of time. That's creating a seed of hope. It's creating connection. It's allowing the person to be heard. Here's what you don't need to do. In that period of time, you are not going to solve or fix the broad problem of crisis of intimate partner violence. These are often, for many individuals, chronic experiences, and they may be living with IPV for long periods of their life, of time. We're not going to solve it. So don't make yourself feel responsible for solving it in that short period of time. You don't need to advise that they need to leave the relationship. That is a choice for the individual to figure out, will they leave? And within the context of a safety plan, are they going to stay in the relationship and hope that maybe their partner gets linked to supports to assist them? Don't try to convince them of what you think is best. You should call 911, or have you called the police, or you need to get a protection order. No, you don't need to convince them of anything, because individuals may have their own experiences or perceptions around other systems. You may feel that these are safe resources that will be helpful. That individual may have past experiences where they feel, that doesn't feel safe to me yet. So we don't have to spend energy or time convincing them. Your work is to offer options, to support them to think about what are the best options for safety for them and to connect. I've talked about asking. You don't need, in these short periods of time, to ask all the detailed questions that force them to relive or re-experience their traumatic events. Because if you spend time doing that and you start to see the individual become really dysregulated and stressed, then this has created another problem or another challenge. And then there's the responsibility to engage in activities to calm, to ground the individual. So just know that that can be a trigger for some of that. You don't need to analyze what happened and why, or think through the problem solving. And you don't have to pressure them to tell you what this whole experience is like for you. So be kind to yourself in recognizing all the things that you don't need to do. So again, just in summary, and I think I've said it a few times, I know it's taken an hour to go through the pathway, but really in practice, we've thought really critical as a team of, in these short episodic encounters, again, the intake line, clinic, a group setting, at the hospital bedside if you're a screening liaison nurse, what does it really look like to identify and respond to IPV? And it requires a healthcare provider to be aware of common indicators of IPV. Again, have a few open-ended questions that you can ask about relationship safety. And think about your language there. You're not asking about violence and abuse. Start gently, start safely. Ask about a sense of safety within a relationship. Just create that space. Listen to what they're saying. If you have a disclosure, inquire what's their immediate need. Identify any factors that might influence your capacity or their capacity to address those needs. Throughout this entire process, validate, believe what they're sharing with you. And then most often within this process, you're going to be sharing resources with them, sharing an app, or through a process of warm referrals, linking them to other providers or supports that then can enhance safety and offer additional support. So thank you for that. I hope that this pathway resonates in those short encounters. And I just want to share with you that through our needs assessments, through our conversations with teams across all 29 health units, and as well as after the release of the perinatal mental health care plans, we heard from the field that there is ongoing needs to really think about this issue of intimate partner violence and how to understand the experiences of individuals who experience it, and what is the role of health and social care providers when working with individuals who are experiencing violence. So we heard that need. So our plan is for many webinars in this series to present webinars on IPV. And we're going to move beyond the surface. You are professionals, experienced professionals that have worked with this population and populations at risk. So we're going to present some webinars that provide you with some really in-depth information. Next month, Marilyn Ford-Gilbo, again, who developed the lead for developing the iHeal app, as well as one of the lead researchers who has developed the iHeal intervention, which is currently being implemented at 2 Ontario public health units, is going to come and discuss next month about how experience of intimate partner violence significantly impact and how it has an impact on both the physical health and mental health of women. In November, Karen Campbell from York University is going to come and give us a really deep dive on all of the resources, processes, mechanisms of the iHeal app. One of my colleagues from the United States in December is going to then come and talk about trauma and violence informed approaches to conducting risk assessments for those experiencing IPV. And a risk assessment is a process once we've identified that someone is experiencing violence to determine what level of danger they're in, and to begin to determine their risk for femicide, for being killed, or escalation of violence. And those are difficult conversations and require asking about details of their relationship. And so really thinking about how to do this in a trauma and violence informed way to minimize the stress or the trauma involved in that type of assessment. So stay tuned, those links will come out. So I want to thank all of you, and with our remaining time, really excited to answer a few questions.
Thank you, Susan, for that excellent and insightful presentation. You're such a skilled communicator. Thank you for sharing the relieves pathway with us and those incredibly helpful scripts and suggestions for talking about IPV, as well as for that reminder that we can all do this work of acknowledging, listening, and validating. So we will now move into the Q&A segment to answer some questions from our live audience. I will start with a question first about the relieves pathway. So can you please clarify what in particular was adapted or revised in the relieves pathway from the lives protocol? What, if anything, did you add, take away, or change?
Okay. So the lives protocol from the World Health Organization has the 5 letters of listen, inquire, validate, enhance safety, and support. So all of that stands the same, right? You could see that those stand the same. But what we recognize, both in working with our colleagues from the World Health Organization and UNICEF and the different research circles that I hang in, is that as a healthcare provider, you can, lives starts with a disclosure, right? So once you hear a disclosure, then you listen, you inquire about their need, you validate, you enhance safety, and you connect to support. What some of my qualitative research and work with public health units has shown is that we actually need to provide supports for clinicians on how to get to the disclosure part. So in it's not published yet, but in a recent chapter where we have written about the relieves model, we've added those additional parts, right? So all those extra steps to get to the disclosure. So know that lives listening means the healthcare provider has heard a disclosure and lives kicks in after the disclosure. We were like, I think nurses in particularly working in contexts where they might not be working with populations or where it's not just part of their regular day that they're asking about IPV, we need to give them a little bit more of a robust framework. So we added those other parts of how to get to a disclosure if it's going to happen. So hopefully that makes sense.
Yeah, absolutely. Thank you. Another question that we have, this one says, I've had clients express to me that they were reluctant to disclose earlier, fearing CAS involvement due to the duty to report and possible outcomes. What could be a good response to this, aside from just validating their feelings or that warm referral, as they want to know exactly what will happen to them and their children?
Okay. I think we need to have a whole webinar on this. I know that last year we were trying to find someone in Ontario who could speak to about trauma and violence informed approaches to referrals and responses. So if anyone out there knows someone, please let me know. Okay, I think you've already started to answer your own question. If an individual has children, we need to be aware of our limits of confidentiality. And as we're doing our assessment and we're considering if children are exposed to intimate partner violence, and we start to recognize that within our community or under the legislation that this meets, their experiences meet the requirement for you to contact Children's Aid as a mandated reporter, that needs to be clearly indicated to the individual, right? That there are limits to confidentiality. And because of what they have shared, this requires a response to assess and increase the safety for themselves and their children. And so I think that it's, the important principles: explain the limits of confidentiality, frame it as this is important for your safety and the safety of the children. This, if you have time, explore, are they already engaged with CAS? What have been their past experiences? Listen and validate some of that, because if they've had past experiences, it may be positive, it may be negative. One of those situations is, if it's possible and it's safe for you and for them, how do you use a warm referral process? How do you, again, facilitate this report, letting them know what you're sharing? When you contact the social worker, the intake worker at CAS, start by acknowledging the individual's strengths, what that mother is doing well or what that individual is doing well. Very often other prior providers may start from a deficit assessment or start by talking with all that's what's wrong. Start by identifying in your report what are the strengths of the individual, and if it's possible within your role, how can you be part of this process to support the individual? The last part of your question says, as they will want to know exactly what will happen to them and their children, 100%. And I think a critical nursing intervention, and again, I'm speaking here to the nurses on the call, other professionals may have different language, different interventions that fit their discipline. But in nursing, the intervention of anticipatory guidance, telling people what to expect before something happens, is a critical nursing intervention to reduce anxiety or to help people think through what they need to prepare for. So I cannot emphasize enough how important it is, if you are working with individuals with children, that you or your team have had conversations with CAS to say, if we make these reports around children's experiences or exposure to intimate partner violence, what happens next? Walk us through the assessment, the intake, what meets the threshold for a social worker or a CAS worker to go to the home. Do they understand the complexities of IPV and the importance of not blaming the mother for keeping their child in an unsafe situation? Do they understand the complexities? I think it's really critical at local levels to have those conversations with CAS so that as a nurse, when your client says to you, okay, you have to make a report, what's going to happen to me and my children now? That you have an answer. You can tell them what to expect. So I think those are really important conversations to have at a local level. And several years ago, we did a study in BC within the context of the Nurse Family Partnership Home Visitation Program, mapping out how public health nurses recognize and respond and navigate mandatory reporting. And one of the findings from our study was about inconsistency in response. I think the most common finding was that everything's inconsistent. The response from individual CAS workers, individual CAS organizations, all seem to have different interpretations and different responses. And so it's difficult to say, okay, at a province-wide level, this is what we do. Because of the inconsistencies, and I would make the assumption it might be the same in Ontario, that's why I advocate for this local response. Meet with your CAS teams, help them be aware of the roles and the values, the roles and the work that public health nurses do, and then learn what they do so you can let your clients know. Thanks, Sonia.
Thank you. That's a great response. This next question comes from She says, this may go beyond the scope of today's practical focus, but within the nursing process, how can we evaluate interventions in IPV care when approaches such as active listening, which are critical to building trust and safety, are not easily quantifiable? How might we frame these qualitative patient-centered outcomes so that leadership and organizations can recognize their value even when they fall outside of traditional success metrics?
Great question. And when you're ready to come back to graduate school, this would be a great study topic. Look me up. It's a great question, and it is a challenge in the evidence and literature on intimate partner violence. Most of the interventions that are evaluated to reduce rates of IPV and to improve women's quality of life do not or have not measured outcomes related to quality of the relationship, quality of the therapeutic relationship as a mechanism that may contribute to these hard outcomes that are typically evaluated in trials. So I have not seen that this is measured. It may be out there. I have not seen that to date for the reason that you have identified, that it's not easily quantifiable. And this is, a question that's as a member of the expert panel member for the RNAO, as the intimate partner violence guidelines are updated, this is going to be a question that's asked there. The great thing is that the world of evidence and the development of best practice guidelines now recognizes the value and the importance of including qualitative evidence into best practice guidelines for these types of topics. So know that in practice guideline, best practice guideline at those higher level organizations, these types of qualitative evidence is going to be included in best practice guidelines. But you're asking like at an organizational and a leadership level. And I think that it's, it comes down to exploring people's beliefs and understanding around qualitative evidence versus quantitative evidence, recognizing that they answer different questions, that qualitative studies, when conducted well, are just as rigorous as quantitative evidence. So it almost becomes an activity of supporting leadership to understand qualitative evidence is equal but different to quantitative evidence, that there are critical appraisal tools to evaluate it, and that qualitative research is the type of evidence that we need to understand about mechanisms and about contextual conditions that influence the work that we do. So that's a short answer to a very complex question. And I think we need to change, what are traditional success metrics that are used in organizations.
Great, thank you, Susan. This question is about the iHeal app, and I know we will have a future webinar that will provide more information about iHeal, but we do have the question of, is the iHeal app also intended for gender-based violence, including LGBTQ plus members, or is it more focused on violence against women?
Great question. And I was just trying to pull up my iHeal app to answer that. But of course it's asking me for username and password that I can't remember right now. I am pretty sure there's some initial questions at the beginning that ask about gender and nature of the relationship who individuals are partnered in. So the work initially, when it was initiated many years ago, was originally grounded in the prevention for violence against women. All the tools and resources and interventions in the work that we do now is expanding to recognize that any individual is at risk for intimate partner violence, and particularly individuals who are members of the LGBTQ plus community are also at disproportionate risk for experiencing intimate partner violence in their relationships. So I'm fairly certain that as part of the algorithm, when individuals enter information about gender and type of relationship, that the information provided will align with the type of relationship that they're in, and it's not limited to women. However, I'm going to ensure that when Karen comes in November, that she answers that. And it's a free app. Anyone can download it and take a look as well.
Okay, great. Yeah, thanks for hearing about that. This question, and I am not aware of one, but is there a peer support network for public health nurses to share and discuss their experiences? I'm guessing this is specific to intimate partner violence. Maybe we have some suggestions of other places. But
yeah, I'm not aware of a peer support network specific for public health nurses. And I think this is where the value of organization. So if there's any organizational leaders out there, managers or above, recognizing the value of creating space for individuals to have reflective supervision or peer debriefing. So even having a team lead that has some skills in reflective supervision, or opportunities within teams to really talk about how complex and difficult this work is. And it's going to occur at different levels. When, again, as part of my research with Nurse Family Partnership, we developed an intervention for supervisors for reflective supervision in supporting nurses who are working with clients experiencing violence. And the most common concerns that we heard from supervisors and nurses were around nurses needing to talk about all the feelings when they walk away from a home visit that they carry with them, worried that their partner, or not their partner, worried that their client will be killed, worried that they're going to see their client in the headlines of the Globe and Mail, worried that they're not doing enough, that they can't solve it, that they can't fix it. We heard a lot about, and we always said, especially in public health, we're not here to fix things, it's not a responsibility, but there is this internal, I can't fix it, am I failing? So all that research showed that there's a huge number of emotions that people carry with them. And then there's the additional complex layer for nurses who are also experiencing or have experienced IPV in their own lives, and how they navigate that, balance that, heal themselves, reconcile that when they're working with a client that might be at a different stage of change or a different stage of readiness to address the violence in their relationship. So for nurses who have those personal experiences, most organizations will have EAP programs. Hopefully health units have policies for how to support domestic violence at work when an employer is experiencing domestic violence. And, for that peer support, I'm a great advocate for, are there the resources, time, and space? And do we have supervisors who are skilled, not just in clinical supervision, but in reflective supervision, creating that space where people can talk about the complexity of this work. But I don't know of any peer support network. I don't know if in one of the communities of practice, if that becomes a subtopic, if someone wants to take that on as well.
Thank you. And sort of a related question, but someone's asking, can the reflective supervision training that's been provided to nurse family partnership management maybe be offered to HBHC management? I don't know that you would have an answer to that, but it's nice to see that they would love to be able to offer this to their team as well.
Yeah, great question. Nurse family partnership is a program that health units sign a licensed agreement to deliver. And all of the materials, including ones that I have developed, the copyright is held with the University of Colorado, Denver. So if your health unit is not currently offering NFP and would like to offer nurse family partnership, I would encourage you to connect with Middlesex London Health Unit, who holds the license for the program, and see if you're a health unit that can start to offer NFP. Then yes, you would be able to access the specific NFP reflective supervision training. However, I recognize that that's not always possible for all health units, or you're not at that stage of thinking about bringing in a more focused home visiting program to integrate within HBHC, because it is part of HBHC. But I think that just, it makes me think, okay, is there another research study here? How can this be adapted to HBHC? And what resources are not copyrighted and can be shared? So it's one that I'll have to think about, but the NFP cannot be, but we could probably think about an adaptation for supervisors and managers that does not include the copyrighted materials. So I'll add that to the to-do list.
Okay, great. And I'm going to bring Sarah, I think, on for the closing. I'll just say this webinar is being recorded, and so it will be available for viewing after. I know there's been a couple of questions around making this available later for anyone who might not have been able to watch.
Thank you so much, Susan. As we wrap up today's webinar, I'd like to thank you for such an interesting and eloquently dealt with topic. As well, I'd like to thank Sonia for co-moderating with me today. And of course, a special thank you to everyone who joined us for today's webinar. You can expect to receive a brief and anonymous survey for today's session. Please try to complete this to help us improve our programming. And thank you and have a wonderful day.